This video is going to help you with the last half of the Chapter 12 notes, Chapter 12 being about the central nervous system. We are starting at define EEG and distinguish between alpha, beta, theta, and delta brainwaves. For your definition of an EEG, you need to know that it does stand for electroencephalogram, which is the blue word that you see up there. An electroencephalogram is a device that you have to hook up to the person's scalp, like you can see in this picture down here, and then it records the electrical activity that is going on in the brain. If you were to hook a person up to an EEG, you would notice different kinds of waves might be seen, whether the person is awake versus asleep, concentrating versus they have some brain damage. For the distinguish between alpha, beta, theta, and delta brain waves, if you get what it says in the picture from your book after it, like you should know that alpha waves, that's a person that's awake but relaxed, and so on. That's going to get you mostly what you need to have there. Another comment that I do want to make specifically about the delta waves, when I find that one here, if an adult has delta waves while they are awake, it can indicate that they have some brain damage, and so that's something that you would hope to not see if a person is hooked up to an electroencephalogram. Another little note to make about EEGs is they can also be used during sleep studies to find out whether or not a person is getting good quality sleep. After that one, you have define epilepsy, including the types of seizures discussed in the book, how an aura can be helpful, and the treatment options. For a definition of epilepsy, I do want you to know that it's a seizure disorder. Let's see, after that one, for the types of seizures, I want you to know the two that are up here on this screen, that there are absent seizures, also called petit mal or petit mal seizures, depending on how you want to say that. What basically happens there is a lot of times the person is still upright, their eyes are still open, but if you were to wave your hands in front of their face, they would not see it or react to that. For a grand mal seizure, that's the one that typically people think of in their head when they hear the word seizure. That's falling down on the ground, thrashing around, sometimes biting through tongues. For explain how an aura can be helpful, some people who have seizures experience a hallucination just prior to having their seizure. As it says up there, maybe they taste something just beforehand, maybe they get flashes of light, maybe they have a specific smell that always comes right before a seizure. That little hallucination can warn them that there is a seizure coming. That way they can prep for it. Maybe they can put in a bite guard. Maybe they can lay down on the ground so they don't fall down on the ground. But that's how auras can be helpful. Treatment options for this, there are drugs that can reduce seizure activity. I give you valproic acid and GABA as different options for that. Dilantin, I believe, is a brand name for one of those types of drugs. For a surgical option for people who have severe seizures, they can implant a vagus nerve stimulator. Of course, vagus nerve is one of our cranial nerves. It's cranial nerve 10. And what they do is they hook it up. What is believed to happen during a seizure, it's kind of equivalent to fibrillation in the heart, where the brain just has a bunch of chaotic activity. By essentially shocking the vagus nerve, it resets the brain in the hopes that the seizure is going to either stop if it's happening or prevent it from happening to begin with, is ideally how that nerve stimulator is going to happen. Now I want to come back to these pictures for just a second. There is a movie that came out a while back. I think it was called My Sister's Keeper, where the lawyer in the movie had a dog that he brought with him everywhere, and it wasn't until the end of the movie that they realized that it was a seizure dog. Dogs are sometimes capable of indicating when a person is about to have a seizure for people who do not have auras. And so these two dogs right here, these are epilepsy or seizure dogs who can indicate that. I also want to mention a story from several years ago. Now the seizure dogs, in some cases, they will wear the vest like this one has. If a person has a vagus nerve stimulator, they are usually given something like a magnet that they can pass over it when they know a seizure is about to happen. That will stimulate the vagus nerve like we described earlier. In the case of the seizure dog, sometimes the seizure dog can be given the magnet in a little pocket in a vest. If you have a young child who doesn't understand what's happening to them, the dog can sense the seizure, place his vest directly over the vagus nerve, and then basically the dog can turn that vagus nerve stimulator on. And so this is one thing where a seizure dog can be tremendously helpful. Now going back to the news story, it was in the Dallas school district, and there was a young child who had a seizure dog that helped him out, and the school district did not allow the seizure dog to come into the classroom because it hadn't been trained by the correct organization. What I just kind of want to point out is these are tremendously helpful dogs. I get why the school district wanted them to be properly trained, because if you're in a special needs classroom, Maybe a kid could run over it with a wheelchair or pull on their tail because they don't know any better. And so you've got to, you know, from a liability standpoint, you've got to make sure you're keeping the kids safe. But this was a kid who couldn't go to class because he couldn't have his dog with him. And so it's just one of those things where you should be aware, for a person who has seizures, seizure dogs are available out there, and they can really help a person who has epilepsy, especially if they are not capable of stimulating their own vagus nerve stimulator. All right. After that, you have defined consciousness. What I kind of want to focus on there are the clinical definitions. Basically, there's what's known as the Glasgow Coma Scale. I'm not sure if I still have the picture. Darn, I thought I had updated it. The Glasgow Coma Scale gets used to basically test stuff like reflexes and can the person answer questions, and then you get a number at the end of it, and a higher number indicates everything is okay. If they have a low number, it means they're either in a coma or they're in a vegetative state or they're essentially dead. And so that's a number that gets used to essentially kind of get you these words. Awake and alert means the person's capable of answering questions, they know what year it is, everything seems fine. Drowsiness is you're asking them questions and maybe they answer 1 out of every 3 questions that you happen to be asking them. Stupor is they're not responding to you pretty much barely at all, and if they do respond, they're not actually answering the question, they're saying other things about totally unrelated subjects. And coma is they're completely unresponsive to you no matter what you do to them. Syncope is how you say this next word. Syncope is essentially the person has passed out. What it can mean is they did not have adequate blood flow to the brain at one given time, and so the brain essentially makes you lie down so that hopefully blood will go back to the area. So that's what syncope is. Coma is the person is unresponsive to stimuli. Some people wake up out of a coma after a couple of hours. Some people stay in comas for years and wake up. There's a lot that we don't know about comas and how they work. A final thing that I want to mention about just consciousness as a whole. Brain death is defined as having a flat line on the EEG. A person can have a flat line on the EEG and still have a heartbeat because the heart beats on its own without the brain telling it what to do. Now, the brain can speed it up or slow it down, but the heart still beats on its very own. So there's a difference between your body is full on dead and your brain is not doing anything for you anymore. I like to always mention this case since it happened. It's been years now, but this is Terry Schiavo if you are unfamiliar with the case. There was also relatively recently a case in Dallas where a pregnant woman suffered from a pulmonary embolism and she went into a coma and she was brain dead or in a vegetative state. The family had known for the pregnant woman, they had known that she would not want to be kept in a vegetative state, but because she was pregnant, the hospital kept her alive essentially as an incubator. The reason that I'm mentioning all of these things is for your personal use. If you have not discussed with your family what you want to happen for any given situation that might occur in your life, it's important that you have that talk. It's important that your family knows, do you want to stay in the coma and hope for the miracle to happen, or do you not want to live like that at all and you want them to unplug you? There are DNRs, which are do not resuscitates. There's also living wills. That's where you can have a person make those decisions for you. And so if you haven't ever discussed that or seen a lawyer about it, you really need to make sure your loved ones know what they want to do so that it doesn't become an argument after you're already in that situation and now nobody in your family really knows what you want. And so just if you haven't had that conversation, it's a hard one, but please have it with your family just so they know what you want. All right. After that, you have compare and contrast the events and importance of slow rave and REM sleep and indicate how their patterns change throughout life. For this one, I gave you guys a National Geographic article about sleep from 2010. It explains sleep better than your textbook does, and it shows you how sleep can change over the years, and so it's just a better article. I'm going to recommend you go read that. For what I want you to focus on here in the notes, here's what we know about sleep. We know that you have to have it or you will die. We don't know why you die from lack of sleep. There have been numerous times where they've used rats in lab settings and they've kept them awake and they die. On a necropsy, though, there doesn't appear to be anything wrong. Their kidneys are fine, their liver is fine. We have no idea why they died, but they died. So we still need a lot of research on sleep because right now all we know is you need it or else, but we don't know how we can help people who can't get the amount of sleep, because basically you have to give them drugs that are either addictive or it causes really weird side effects. Like if you've ever seen a person on Ambien, it does weird things to them in their sleep. Hospitals don't like to give people Ambien because they will get up and walk around the halls and then have no memory of it the next day. So those drugs are really scary. But you do need some sleep. If you read the article that I gave you there, it also points out that there is a weird recessive disorder called fatal familial insomnia, which appears to be either genetic or a prion disease. And in that case, people lose the ability to fall asleep and then they die. So again, you need sleep or you will die. It's pretty much that simple, but we don't know why. The other thing that I will mention is this picture on your book describes the stages of sleep. REM sleep is restorative sleep. This is what you need in order to stay alive. Notice that you don't just go down into your stages and then stay there for the whole night. Everybody goes down and back up, down and back up. Kids can stay down in the lower stages longer. Older people tend to fluctuate more briefly throughout the stages. But that's basically sleep in a nutshell. Study that picture and you'll be okay. All right, next up you have diseases of sleep, starting with narcolepsy. There was that movie Deuce Bigalow, or yeah, I think that was the name of it, where he would go out on dates with different women, and one of them had narcolepsy, and he had basically asked her at one point, like, what is your dream, what do you wish you could do? And she said, eat soup. Which sounds like a weird thing, but the thing about narcolepsy is the people lapse into unconsciousness apparently randomly, just poof, they're asleep. And so you could see why soup might be a scary thing for a narcoleptic, because if you just poof, fall asleep into your soup, you're going to drown. But that's narcolepsy. You just lapse into sleepness from a wakeful state. Next, insomnia means that a person is not able to get the amount or quality of sleep that they actually need. There are treatments for it, but again, the drugs are either addictive or they have really weird side effects. There are lots of books out there now that can help people with insomnia. We had already briefly talked about melatonin in an earlier thing. Reduction of stress is a huge part of helping with a person's insomnia, and so that's what you've got to really try to do, is help with your stress levels, and that can help with your insomnia. Next, sleep apnea. It's really a respiratory issue. Sleep apnea means that the person stops breathing while they sleep. People who snore fairly loudly are more at risk for this. People with an excessive amount of weight on the body are also more at risk for this. But if a person has sleep apnea, what happens is when they stop breathing, they come out of the slower stages of sleep earlier than they should have, so they're not getting the restorative sleep that they actually need, and so they will just feel exhausted for days and days and days because they keep having to wake up to breathe. You can do sleep studies to figure out what's wrong during a lot of those. All right, next up, memory is the ability to recall facts. Short-term memory, you can get your definition for that right there. The important stuff is you can really only put small chunks of information into short-term memory, like a phone number. Long-term memory can, in theory, be in your brain for your whole entire life and never be forgotten. Long-term memory is also not only short pieces of information. You can store whole events in your long-term memory. For what 4 factors can help transfer a short-term memory into a long-term memory, these are some of the things that you have going on right here. Number 1, let's see if I have it on the slide. Okay, number 1, emotional state. If you are emotionally invested in a topic, it matters to you, you are more likely to remember it. And this is why people remember the birth of their child or their wedding day. They're emotionally invested in those days. That's not going to help you study for your A&P test, though. And so next up you have rehearsal. Rehearsal means practicing. Get some flashcards, highlight and read your notes. The more you look at it, the more likely you're going to remember it. And this is something that can help you on your next A&P test. So just repeat it often enough and you are more likely to remember it. Association means if you learn a new fact, you type something old. And this is where some of the questions that you guys ask in class are helpful. Like if I mention epilepsy and you're like, hey, my uncle has epilepsy, you're tying that new bit of information that I'm giving you to a memory that you already had, your uncle having it, and that makes you more likely to remember what I've said in class. So this one, you really can't help it if you have something to associate it to, but it can help you remember some of the information. The 4th and final way, you can't do anything about it. Automatic memory is something that just gets stuck in your head for no apparent reason. You might not even want to remember it, but it's in there and you can recall it for no apparent reason. So that's automatic. Next up. if you were to look at a cross-section, or this happens to be a frontal section, through the brain, you're going to notice a lot of different layers that help to protect the brain. Of course, you have your skin, your periosteum, you've got the various bones, frontal bone, parietal bone, temporal bone, occipital bone, all those nice little bones. You've got another layer of periosteum, and then you get these new layers that we haven't seen before, the brown layer, the purple layer, the blue layer. The brown layer, the purple layer, and the blue layer all collectively together are your meninges in plural. This is the word. Meninx is singular, meninges is plural. One of those layers helps to create a current of cerebrospinal fluid, which is mostly going to be stored between the purple and the blue layer here in this picture. The cerebrospinal fluid is going to be acting like a cushion. Okay, so here's the purpose of those three layers for describe how they help to protect the CNS. They help to anchor the brain and prevent it from moving around too much. They also help keep bad things out of the brain, and that they are forming a layer that's keeping pathogens out of the system. Now that also ties into the blood-brain barrier made from astrocytes that we learned about back in chapter 11. The astrocytes wrapped around the capillary and prevented bad substances from entering into the neurons and then damaging the brain itself. So the brain not only has this to help anchor it and keep pathogens out, we also have the CSF that has antibodies and things like that floating around in it, and we have the blood-brain barrier that helps to make sure the CSF stays clean as it's circulating through everything through here. Now, for each of the color-coded layers that you have in there, we're going to be starting with the dura mater. It is the brown layer. It is the most superficial meninx that you have. It is made out of the toughest connective tissue, aside from bone and cartilage, that you have. And really its job is to do the anchoring. And so what happens is it dips in between some of the deep fissures of the brain, and then it prevents the brain from moving around too much within the cranial vault itself. It does also in a few places, like along the sagittal line and then along the transverse sinus right through here, it creates special blood vessels called dural sinuses. Instead of just having capillaries formed together into venules which form veins, we instead get these sort of pools that collect blood coming from the brain, and then those pools are going to eventually drip the blood down into the jugular veins. Those pools are called dural sinuses, and so the dura mater helps to make the dural sinuses, which are going to help the circulatory system keep blood moving throughout the brain. Next up, the purple layer in the picture is the arachnoid mater. This is the middle meninx that you have. The most important feature to me for the arachnoid mater is it has these little structures called arachnoid villi, is the plural form. As we create cerebrospinal fluid, we have to be able to drain off old cerebrospinal fluid. And so what happens is these villi drain the excess fluid into the dural sinuses, and they mix it in with the blood. That helps to reduce pressure and keep it low within the cranial vault. And so this is helping to keep that pressure low. Later on, we're going to talk about hydrocephaly. That's failure of these villi to drain that excess CSF out of the system, and so pressure starts to build up. So we'll come back to that in a little bit. Final layer that you have is the blue layer, and that's the pia mater. It's the deepest meninx, it's the most delicate meninx, and it's also the only one that was still present when you guys dissected your brain in the lab. It actually prevented you from dipping down into the sulcus within the brain, or each sulci if you want to look at it from a plural state. Next thing that you guys have in the notes is choroid plexus. As you look at this view of the brain, there are these little areas where there are red structures. Those are the choroid plexuses, which that is not the proper way to say that. Those are essentially leaky capillaries, and what happens is a lot of the plasma leaks out. As it's being leaked out, we control the chemicals that go inside of it, and then that plasma that's been filtered and controlled ends up becoming the CSF. So another way to say that is the choroid plexus makes the cerebrospinal fluid. Next word in your notes is meningitis. That is inflammation of any of the meningeal layers. It's on this slide for pia mater. It can be the dura mater, it can be the arachnoid mater, and quite often it's all three of them all at the same time. After you get that it's inflammation of these layers, I want you to know that it can be bacterial or viral. If it's bacterial, we can treat with antibiotics. If it's viral, we cannot. The way that we diagnose meningitis is by collecting a sample of cerebrospinal fluid, and we do that with what used to be called a spinal tap. The proper term for it now is called a lumbar puncture, which is abbreviated LP in patients' charts. What they would do is try to culture what's in the lumbar puncture. If it comes back as bacterial, we know how to treat that. Final note for you guys to make for meningitis. For the bacterial forms, there is a vaccine. That's even the vaccine they make you guys do before you come to college. For the viral form, there is no vaccine. The viral form is usually fairly weak though, and so you have a better chance of surviving the viral form. Next thing in your notes is hydrocephalus. I alluded to this one earlier. In Latin, that literally means waterhead. What's happening here is you're still producing cerebrospinal fluid. You are not draining the excess fluid out, so it's just accumulating within those meningeal layers. When you're an infant, as in this particular case, remember the skull's not fully formed yet. We still have those soft spots or fontanelles, and so the skull can actually balloon out. You'll notice that we can go in surgically and we can put shunts in to drain that fluid, and usually life is all better after that, but you do want to catch it early. If an adult develops this, the skull is fully formed and their skull is not going to balloon out. Instead, they're going to get excruciating headaches, and then they're still going to have to go in to do the surgery to treat it. It's just not as visibly obvious when an adult has hydrocephalus because the whole cranium doesn't swell like this. That's a good place for us to stop on this one. We're going to pick up at injuries and diseases in the next video.